A very good afternoon and welcome everyone. I, 𝗗𝗧𝗘𝗧𝗘𝗡𝗖𝗧𝗏 on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of Ovarian Cancer Awareness Month, Voice of Healthcare has taken an initiative to bring together the experts and speakers for this resourceful discussion today. In this discussion, our speakers will talk about the signs and symptoms, latest trends, and approaches with the focus on how early diagnosis can save life. I would like to commence this session by introducing our eminent speakers. We have Dr. Shyam Aggarwal. He is a chairman and director of the Department of Oncology at Sir Ganga Hospital, New Delhi. Welcome, Dr. Aggarwal. We have Dr. Meenu
Thank you.
Walia. She is Senior Director of Department of Medical Oncology at Max Super Speciality Hospital, Vaishali. Welcome, Dr. Walia.
Right.
We have Dr. Suruchi Aggarwal. She is a Senior Scientist in Oncology at MedGenome. Welcome, Dr. Suruchi. We have Dr. Pallavi Shukla. She is an Assistant Professor of Department of Oncology at AIIMS, Delhi. Welcome, Dr. Shukla.
Thank you.
We have Dr. Viveka Belathur. He is a consultant of Department of Oncology at Fortis Hospitals, Bangalore. Welcome, Dr. Vivek Belathur. So,
Thank you.
along with sharing his views, Dr. Vivek will also be moderating today's session. So, without further delay, I would like Dr. Vivek to lead this session. Over to you, Dr. Vivek.
Thank you, Suruchi. I once again welcome all of you and my esteemed panel for this today's discussion on ovarian cancer, which is a very important topic for discussion. So I welcome you all once again on behalf of Fortis Cancer Institute, Bangalore. So, September month is considered as Ovarian Cancer Awareness Month, and aptly this year, I think they have this theme, early diagnosis saves life. I think it makes sense because as all of us know that ovarian cancer, is a cancer which, in majority of the times, this particular condition is diagnosed in advanced stages, unfortunately for various reasons. And that is why creating awareness among public, among the people, among women about this particular cancer, as far as the symptoms are concerned, as far as the early diagnosis is concerned, treatments are concerned, I think it's very, very important. So just to give a brief overview of the problem. So ovarian cancer is one of the most important cancer among women in India and elsewhere. So this is the third most common cancer among women after breast and cervical cancer in India. And the incidence is increasing. Unfortunately, as I said earlier, majority of the these ovarian cancer patients are diagnosed in advanced stages. So it is difficult to pick up these cancers in their early stages because of the misleading symptoms. So there have been a lot of advancements in terms of the treatment for this condition, but still there is large unmet need. And since majority of these advanced cancer patients are not cured, so we need to be aware of how we can diagnose this problem in its early stages so that we can offer them better treatment and make it curable. So there is definitely more need for awareness among the public, among the women about these problems. So to discuss about this and more, let me start my panel discussion with our esteemed panel doctors today. So first question I would like to ask Dr. Shyam Aggarwal sir about the early signs and symptoms of this ovarian cancer and also the causes of ovarian cancer. Sir, if you could explain our audience.
Right. So thank you very much, Dr. Vivek, for this opportunity and inviting all of us to discuss this important subject of ovarian cancer. So coming to the first question, which is what are the symptoms of ovarian cancer? So I think, as you pointed out earlier, that in early stages in ovarian cancer, there are hardly any symptoms. So, that is the biggest problem, that we are not able to, advise people for a particular test or a symptom to watch out for to pick up ovarian cancer in early stage. So therefore, the symptoms are mainly occurring in patients when they have gone on to, stage 3 or stage 4, and those symptoms can be divided into 4 or 5 subgroups. The first can be some kind of pain in the abdomen or in the pelvis region, which could, be due to the ovarian cancer or ovarian tumor. The second set of symptoms can be related to gastrointestinal tract or the intestine, in which they can have some bloating, some change in the bowel habits, indigestion, or nausea. So, these are 3 or 4 symptoms which are relating to the intestinal disturbance. The third symptoms can be categorized in the abdominal fullness, or they can even feel some kind of a lump in the abdomen or fluid in the abdomen, which can result in, enlargement of the stomach. And the final symptom can be related to the tumor, in the sense that they can have weight loss, they can feel less hungry, or they can have fatigue. So these are vague symptoms which can occur in so many other diseases or so many other illnesses. But I like to stress this point that if these symptoms, which are very common actually in day to day life, if they're persisting for 3 weeks or more, well, then you should have some suspicion that there can be something wrong in their body, and therefore they should go and see a specialist, which could be a physician or a gynecologist or a gastroenterologist, and they should subject themselves to investigations such as blood tests, ultrasound of the abdomen, and if required, a gynae checkup. Because, the cancer symptoms are not going to disappear unless the treatment or the diagnosis is made. But if somebody has some indigestion or some other symptoms, they will spontaneously, or with medicines like antacids and pantocid, etc., they can subside. So I think a persistence of a few symptoms, and rather worsening of those symptoms in 2 to 3 weeks' time, should alert a person to go in for some kind of evaluation by a trained physician or a gynecologist. The second question was the causes of ovarian cancer. So there is no known cause as such for cancers in general, but yes, there are certain predisposing factors, such as obesity. If you have put on a lot of weight, during your life, so that is one contributing factor. Then your dietary and lifestyle habits, if they are sedentary, so those are, other contributing factors for developing cancer, which is including ovarian cancer. And I think the most important thing which one has to realize is a family history of, as we call it as HBOC, which is hereditary breast ovarian cancer syndrome. And I'm sure this will be addressed, in greater length in the subsequent, panel discussion. That if there is a family history of breast cancer or ovarian cancer or pancreatic cancer, or in men prostate cancer, if there's a family history, and then you really, depending upon how strong the family history is, so one has to be careful for screening for ovarian cancer early in their life.
Absolutely, sir. Thank you very much, sir. So, as you rightly pointed out, unfortunately, ovarian cancer symptoms are highly misleading. There are no one set of specific symptoms which would help a woman or a person to go ahead with further evaluation. So, one need to be aware of these vague symptoms, and that too in the absence of, there are no standard screening programs available, unfortunately, to detect this cancer, unlike in breast cancer or cervical cancer, where we have some screening methods, and in few more conditions as well. So unfortunately, those have been tried and tested and found to be not that useful. So it is only our awareness, our symptom evaluation, which would help in the early diagnosis of ovarian cancer. So thank you, sir. So moving on, I think there's one more important question. Can ovarian cancer be inherited, how influential is the family history in the development of ovarian cancer? Dr. Meenu, Walia ma'am, if you could answer.
Thank you, Vivek. Before I begin, I think a part of the question has already been answered by Dr. Shyam Aggarwal. The question is, can ovarian cancer be inherited? Then the answer is yes. Many ovarian cancers can be inherited, and that is the reason that family history of cancer becomes very, very important in a case of ovarian cancer. So, as Dr. Shyam Agarwal pointed out, so it is not the only the family history. Like most people will feel that if we are talking about ovarian cancer, it is only the family history of ovarian cancer which is important. No, it is not only the family history of ovarian cancer which is important. It is also the family history of breast cancer which is important. It is also the family history of male breast cancer. If any male members of the family have had breast cancer, also the family history of pancreatic cancer, because some of the pancreatic cancers are also known to be inherited, and also the family history of prostatic cancer. So male prostate cancers, like prostatic cancer, that happens like that will mainly occur only in the males. So we all these histories are important. Why it is important is because we know that there is a subset of ovarian cancers which are caused because of genetic mutations which can be inherited. The most common being the BRCA1 and BRCA2 mutation, which are the very common genes that we know that which can cause, which are inherited genes. The mutation in these genes will make you susceptible to lot many cancers, and apart from ovarian, the other cancers which are mentioned. And these genes need, when we say inherited, it means it can pass on through the generations. So that is something which is important. Approximately 20% of the high grade serous or high grade endometrial ovarian cancers are known to be high grade carcinomas are known to have harbor this BRCA mutation. But apart from BRCA mutation, there are lot many genes which we say BRCA like genes, meaning that these are also the genes which can make you susceptible to various cancers, including ovarian cancers. And there they come in a broader subcategory of genes, which we say the homologous recombinant repair genes, HRR genes. So what is important is that, and many of these genes like ATM, etc., can also be inherited. And that is the reason in today's date, we need to know the family history very importantly in all high grade ovarian cancers, literally in almost all ovarian cancers. And apart from that, we need to do the genetic counseling, and we also need to do the genomic testing in these kind of patients. Why? Because it has got implications. It has got implications not only for the patient from the treatment perspective, it has also got implications for the rest of the family members.
Oh, thank you very much, madam. I think you rightly pointed out the importance of this genetic testing. So it's not only for the individual patient for her treatment alone, but also for the rest of the family. I think so. It's very, very important. Thank you. Now we have been talking about early stages and advanced stages of this cancer. So let me ask Shyam Aggarwal sir about the stages of ovarian cancer, that how it would impact in terms of treatment and also for the patient. Sir, if you could answer.
Right. So I think the staging I can simplify for lay people in a very simple fashion. Stage one is when the cancer is confined to one or two ovaries, but there is no extension beyond that. There should be no fluid. We call it as ascites. So that is stage one. Stage two is when the ovarian cancer is confined to the pelvis. For example, it is involving maybe both the ovaries, but it can go to the fallopian tube or the surrounding structures, but it should not be crossing into the pelvis. The third stage is when the ovary is involved, but there is extension of the tumor outside the pelvis into the covering, which we call as peritoneum or lymph nodes or omentum. So that is stage three, but it is still confined to the abdomen. And stage four is when distant organs like pleura, lung, liver, or other bones, etc., are involved. So staging is very, very critical because it has impact on the treatment modalities. because if you're talking of stage 1 and stage 2, when the tumor is confined to the ovary or to the pelvis, then surgery is the mainstay of treatment. And depending upon the type of cancer, you also need adjuvant or subsequent chemotherapy. I mean, it is also important to understand that you can have two types of ovarian cancers. One is the epithelial ovarian cancer, like Dr. Meenu was saying about the high-grade serous. But in younger women, for example, who are under the age of 20-25 years, their germ cell tumors are very, very important. And why I'm bringing out this, younger patients is because we also sometimes have to, we are actually supposed to do the fertility preserving surgery in stage 1 cancer, where we are only going to remove the affected ovary, because a 20-year-old girl would like to, preserve fertility. So there are guidelines for that. And that is very important from the staging perspective and treatment perspective. So when it comes to stage 3 and stage 4, then usually the surgery takes a back seat, and the cancer chemotherapy becomes the first treatment. And then after 3 cycles of chemotherapy, when the patient has improved, the fluid has regressed, and the tumor size has shrunk, then surgery is again very, very important. I want to emphasize this, that the surgery must be performed by a trained gynae oncosurgeon, because we call it R0 resection, where maximum adequate cytoreductive surgery and debulking should be performed. And now, of course, as Dr. Meenu was referring to, that there is a role for BRCA1 and BRCA2 testing. And also there is another test called HRD test for stage 3 and 4 cases, because the role of new drugs like PARP inhibitors is available for patients who have advanced stage ovarian cancer. So I think staging is very, very important. And that requires a CT scan or an MRI and sometimes PET CT scan to determine whether we are dealing with stage 1, 2, 3, or 4. And then the the molecular testing in the form of BRCA1, 2, HRD is required.
Thank you, sir. Thank you very much for really elaborating the importance of staging that well for our audience. So staging is very important once we make a diagnosis of ovarian cancer, because the treatment is determined on that, and we conduct many other tests as well after the stage is made. So moving on to the next question. So we have talked about this condition. So how do we diagnose this ovarian cancer? So what are the various treatment options available in India for this particular condition? May I ask this to Dr. Meenu Walia? Ma'am, if you could answer.
So you want to know what are the various treatment options that are available?
And diagnosis also. How do we diagnose this?
Diagnosis. Okay. So the first question we come to is diagnosis of ovarian cancer. So in a lady that comes with the specific signs and symptoms. So as already pointed out, the signs and symptoms of ovarian cancer are generally very subtle, and they can easily be missed and can be confused with so many other conditions. So one needs to have a high index of suspicion, and one needs to evaluate further. So majority of these patients will generally present like what we see in our clinical practice. They come with early satiety, huge abdomen, bloating of abdomen, or swelling over the abdomen. And when you do further evaluation, you may find ascites, that is collection of fluid in the abdomen. So in majority of these cases, these are the patients who present with ascites, fluid in the abdomen. You can see ovarian masses when you get an ultrasound. So how do you diagnose? You diagnose by having a high index of suspicion. In all these cases, which present with even the vague symptoms of early satiety, abdominal bloating, abdominal fullness, and you further confirm the diagnosis with different kind of tests. These tests can be radiological evaluation. So radiological evaluation will mean either doing an ultrasound or an MRI, where you want to evaluate the ovarian lesions further. So if there is a cyst in the ovary, we need to see whether it is a malignant cyst, it is a solid cystic lesion, or it is a complex cyst, which will give me an idea whether it is a malignant lesion or it may be just a normal benign functional cyst of the ovary. So for evaluation of the ovarian lesions, we normally need to do a right combination of ultrasound of the abdomen or a transvaginal ultrasound, or further evaluation may also be done by a MRI imaging of the abdomen. So apart from that, what needs to be done further is we generally corroborate all these diagnoses. We take help with certain blood tests, and these blood tests are known as serological markers. For example, CA125 or HE4, these are normal serological markers, and then certain indices are available like Roma, RMI, etc., which can further guide the physician about the probability of this lesion being malignant. So, a very simple thing that comes is, why not go ahead and do the biopsy straight away? Why we need to make a corroborative efforts with the imaging, with the CT scans, with the MRI or ultrasound, or with these markers, and why not do the histopathological diagnosis straight away? So that has got a meaning. Why? Because in very early ovarian cancers, something like a stage 1 disease, something like which is limited only to the ovaries, where there is no capsular breach, we do not want to upstage the disease by doing a tissue diagnosis, by doing an FNAC or a biopsy. So that is why a right corroboration of all these factors needs to be done. So, however, if the disease is already advanced, as happens in majority of our cases in India, most of these patients will present with huge ovarian masses, or they will present with ascites, or they will present with thickening of the peritoneum, which we say omental nodular deposits, or sometimes the patient may present with a small lymph node in the neck, that is the supraclavicular lymph node enlargement. In these cases, where the disease has already traveled beyond the ovary, we normally corroborate with the tissue diagnosis. We will always want to do a biopsy either from the supraclavicular lymph node or from the omental thickening or from the ovarian masses itself, where we look for the evidence of the disease. Then comes the treatment of ovarian cancers. Again, the treatment of ovarian cancers, like any cancer, depends on the stage of the cancer. Majority of these cancers generally require the combination of one local therapy like surgery and multiple systemic therapies. Radiation therapy, by and large, in most cases of ovarian cancer, we do not use radiation therapy. So the most common modalities that are used is surgery and systemic therapies. Now, the surgeries can also vary. For example, if the disease is limited, is a very early disease, limited to one ovary, and then, as Dr. Shyam Aggarwal has already pointed out, if it is a young girl, germ cell tumor of the ovary, and we know that this girl has to marry tomorrow, and then we will want her to have a normal life, so we will think of fertility preservation surgeries. Similarly, in borderline tumors, in early diseases, you will think of fertility preservation surgeries. In all others, it is generally a complete cytoreductive surgery, where the aim has to be optimal debulking or optimal cytoreduction, where you actually do not want to leave any residual disease. The other important aspect of treatment is systemic therapies. Fortunately, most ovarian cancers, majority of these ovarian cancers are very, very chemosensitive. So chemotherapy goes a very long way and is a very important component in the treatment of majority of ovarian cancers. So apart from a very small subset of ovarian tumors where chemo is not given, I will say less than 5% or so, majority of these patients will receive chemotherapy during the course of their disease, and majority of them, they also respond to chemotherapy. So whether the we use a multitude of chemotherapeutic agents, although two are the ones which are the standard and the preferred, but there can be n number of different agents which can be used in ovarian cancer. Whether we use chemotherapy upfront or after surgery, so that can vary. That can vary depending on the stage, depending on the extent of the disease. For example, a lady is presenting with a node in the neck, which is where the cancer has already gone to the neck, or there is disease, evidence of disease in the liver. So in these cases, we generally go for chemotherapy upfront and later reevaluate the patient whether when optimal, when chemotherapy has had its effect, when there is significant response, whether the patient can be taken up for surgery or not. So apart from that, what is important in today's date is there are a lot of newer therapies in ovarian cancer also. One is a very commonly that we have started using is targeted therapy, or what we can say anti-angiogenic agent like bevacizumab. So in various high-grade tumors where you may use a combination of chemotherapy with these agents, and generally they are given in maintenance also after completing chemotherapy for decreasing the chances of the cancer coming back. And as already pointed out, why we have now started talking so much about genomics in ovarian cancer? Why? Because as I earlier pointed out, knowing that the patient has a mutation or a patient has HR deficiency or HR recombinant deficiency, so if that is there, then these are the patients who may benefit from specific targeted medicines which are available, which are simple oral tablets like PARP inhibitors. And they really can be given in a subgroup of these patients after completing your therapy, where they can be given either in the relapse setting or in the first stage setting also after completion of therapy, by to decrease the chances of the relapses, to decrease the chances of the cancer coming back. So even ovarian cancer therapy, I will rather say, has now come a very, very long way. And with these newer agents, we are now seeing ovarian cancer patients surviving for much more longer time and doing much better in life than any time earlier in the past.
Thank you very much, madam. I think you rightly pointed out two important things, if I can summarize. So I think in ovarian cancer, unlike in other solid tumors where we straight away try to do the biopsy and establish the diagnosis quickly, here we need to be very careful, particularly in early stages of ovarian cancer, where we wouldn't do biopsy because that can actually increase the stage of the disease. And as far as the treatment is concerned, there are a lot of new treatment options available now. So in addition to biological therapy, now we have moved on to targeted therapy, as you rightly pointed out, with a knowledge on mutations, genetic mutations in the tumor, which can be germline or otherwise. So thank you very much. So now I think all this while I think we have been discussing on this mutations in the tumor. So let me ask this question to Dr. Suruchi Aggarwal about this germline mutation. So what is the incidence and the trend of this BRCA1 and 2 germline mutations in India and elsewhere? Dr. Suruchi, if you could answer.
Sure. Thank you so much for providing me an opportunity to be part of this esteemed panel discussion. So, as Dr. Meenu and Dr. Shyam has already set the context for genetic testing in ovarian cancer. So, the incidence of BRCA1 and BRCA2 mutations in Indian population is slightly higher than the other populations. And there are quite a few published papers from Indian data. For example, recently a data of 239 patients was published, and it was shown that there was around 20 to 25% positivity rate for BRCA1 and BRCA2 mutations, out of which BRCA1 was more prevalent, around 15%, and BRCA2 was around 6% positive, and BUS was 1.7%. The interesting part in the testing nuances, what we have seen is that without family history, also the positivity rate for BRCA1 and BRCA2 is high. And in this paper, also 20% of patients without family history were positive for BRCA1 and BRCA2. And also the higher age patients greater than 50 years of age was also positive. That was also 20.8%. So if we select the patients for testing based on family history or young age, or by histology, serous histology also of ovarian cancer, we may miss these patients which could be BRCA1 and BRCA2 positive. So there is similar study which was done in 101 patients, and we saw almost 44% of positivity, and the median age was 47 years for those women. And another study was also there where we would have seen 27% positivity rate in ovarian and breast cancer cases.
So also Dr. Shyam Aggarwal pointed out the importance of HRD testing. So in high-grade serous ovarian cancer cases, 1 in 4 women are BRCA1 or BRCA2 positive, like around 25% positivity, and 1 in 2 women is HRD positive. So not only germline BRCA1, BRCA2, but HRD should also be tested in such women to actually find out those women which are BRCA1, BRCA2 negative, but could be HRD positive due to other HRR defects, which are not dependent on BRCA1 and BRCA2 genes. Another point that we see is that upfront testing, tissue testing is recommended as compared to germline testing, because tissue testing will give an idea of both somatic and germline mutations. However, if we do germline testing first and then go for tissue testing, there is a time implication. If germline testing comes out to be negative, then we go for tissue testing. So if tissue testing is preceded by germline testing, we can get an answer early, and then we can test that positive mutation in the blood of the patient and further in the family for the positivity and for the germline familial implications.
Yep. Thank you, Dr. Suruchi. I mean, I think you rightly mentioned about the importance of this genetic testing in all ovarian cancer. So they have implications in terms of treatment. Although the incidence of this particular mutation in the general population is probably less than 1%, but if we take these ovarian cancer patients, the incidence increases. Basically, we are picking up more of those patients who already have this mutation. So obviously, and the incidence is more among these group of patients, ovarian cancer patients. So so it's very, very important that all of the ovarian cancer patients undergo this genetic testing. So moving on, now we'll move on to the next question, which are like what are the risk factors for ovarian cancer and how can the risk be reduced? May I ask Dr. Pallavi Shukla to elaborate on this?
Thank you, Dr. Vivek. And I think Dr. Shyam, sir, has already touched upon this point about the risk factors of ovarian cancers. So before I move on further into it, yes, ovarian cancer is segregated into various types, and the most common variant is the epithelial variety. And it's like almost more than 90% of all the ovarian cancers are epithelial in origin. And the risk factors which we have studied so far are mainly pertaining to this group of cancers. So, cancer per se is a multifactorial disease, and that is one reason why it is so difficult to pinpoint one factor which is causing that particular cancer. However, with our years of research and so many data that we have collected in oncology so far, we have figured out few risk factors. Maybe if this risk factor is present, this person is more vulnerable to getting that cancer. So, taking that perspective, age is one important risk factor. So, as we advance in age, we are more vulnerable to getting any cancer, and ovarian cancer is no exception. And there are other non-modifiable risk factors like a strong family history, as we have been discussing so far, and a genetic predisposition, like we have discussed with Dr. Suruchi about BRCA1, BRCA2 genes. So, out of all the people who are having these mutations, the BRCA1, more than 50% of them might develop ovarian cancers. And for BRCA2, the risk is a little less. It's around 12 to 20%. The lifetime risk of having ovarian cancer in this particular group of patients who are having this gene mutation in them. Then another non-modifiable risk factor is early menarche, like having your periods before you have achieved 12 years of age, and having late menopause. So it's like more than 55 years of age. So what it's actually happening is we're getting a long period of reproductive span. So multiple cycles of ovulation are happening, and cancer per se develops in those tissues where there is constant division multiplication happening. So once ovulation is there, the repair mechanism is functioning there. So there are chances of spontaneous mutations happening there, which might lead to cancers. So that is one incessant ovulation hypothesis which favors this risk factor like early menarche and late menopause. Then we have certain protective factors also in ovarian cancers, and one of them is having more number of babies. So although it's a double-edged sword because it can be a protective factor for this cancer and would be a risk factor for some other cancer like the CS cervix. So, and another is use of oral contraceptive pills. So they say ki if like you have taken OCPs for more than 5 years duration, that will be a good amount of protection for ovarian cancers. Then there are certain weak protective factors as well, like lactation or maybe incomplete pregnancies as well, because full-term pregnancies are definitely a protective factor, but even incomplete pregnancies have also attributed as some kind of protection. So probably these lactation and incomplete pregnancies are, again, they're just putting a pause in your reproductive lifespan. So that is why they are giving you protection. Then we cannot shy away from the fact that it is also having lifestyle dependent factors, and one of them is obesity. So obesity is a very big contributor for n number of cancers, and ovarian cancer is one of them. So these three cancers, ovarian, uterine, breast, they go together in terms of obesity. So if there is obesity, you are vulnerable to all these three cancers. Then there are certain benign gynecological conditions, so they might pose you at an increased risk, but the findings are not so much conclusive. But yes, endometriosis, PCOS, and chronic pelvic inflammatory disease, they might also add on to your risk of developing ovarian cancers.
Okay, thank you, Dr. Pallavi. I think you rightly mentioned very important risk factors. I think one of the most important is also the age. Actually, as the age advances, I think the risk of ovarian cancer increases. Although the median age has been put out as around 60, 65 years, but we have seen this cancer happening even among younger, particularly in India. I have seen that many younger women in the ages of 35 to 40 or even less than that, we have seen developing this cancer. So any woman beyond the age of 35, 40, I think needs to be aware of these vague symptoms. I think when they strike them, and when they have these persisting symptoms going on for many weeks, I think that's the time to get evaluated. So may I ask Dr. Pallavi Shukla once again about living with ovarian cancer? What are the caregivers information caregivers need to know about, and also tips that need to keep in mind once somebody is on
So
treatment?
as a caregiver for any cancer per se, first of all, it's a very big pressure on caregiver side because they are dealing with the patient and they're also dealing with their own personal trauma, because cancer does not affect a single person, it affects the entire family. So first and foremost, they have to work upon themselves so that they are at a level where they can take care of the patient. So one has to boost their morale first. They have to be at a higher level so that they are at the giver side and not at the receiver's end. Second, there are many stigmas associated with these gynecological cancers. So caregiver burden again increases here as well. So consider somebody's wife suffering from ovarian cancers. So she needs a lot of emotional support from her spouse, right? Because no doubt, fighting cancer, she's also getting rid of much of her femininity as well by losing her important organs, right? So that kind of support will also be required from the caregiver side. And then, so first and foremost, the caregiver needs to be well aware about the disease, the treatment plans available, what all, side effects the patient might be exposed to during the course of the disease and during the course of the treatment. So, like for say, after chemotherapy and all, they'll be experiencing nausea, vomiting, there'll be several episodes of diarrhea. So, they need to be really prepared for to face all these things. And they also need to speak to the practitioner about how to manage those side effects as well. Then they have to deal with the personal issues. They have to provide care in terms of all the patient might be needing help at all levels, right? Other than that, the medical help, dealing with the doctors, talking to them, communicating with them, putting forth their questions, because patient might not be in that position to, come upfront with the doctor and receive and those informations. So helping them maintain their diary and all. And then last but not the least, the financial component of dealing with these cancers, that is also very important, because uh, we in India are not covered with insurance. Like everybody is not covered with insurance. So that kind of vigilance and that kind of support also they will need. So it's like, the entire burden comes on the caregiver, and they really need that much information so that they are able to help their patient. And yes, they should never forget to seek help. So never feel shy in taking help. There are support groups, and maybe the doctors also can help them associate with the support groups. And those support groups actually help them a long way in during the course of illness.
Yeah, thank you very much. I think you rightly, pointed out that we as clinicians, we tend to concentrate more on the clinical care or the treatment aspect of the patient. We almost always forget about the caregivers, stress and other problems they would face. Actually, in fact, many of the caregivers, attenders, what we call them, and they open up of late. But most of the times, I would say, particularly in an institutional practice, training institutes, I think so. We do not give much of importance to the caregiver. Here also, I think that culture of taking care of the caregiver is still evolving. I think it's very, very, very important. I think in all our opinion that we should give some time to caregivers as well, to make them understand the situation and support them as well, because they are going through just not their own kin and kids problem, but also they'll be really under stress. Of late, we have seen that many of these attenders, family members coming out and sitting and crying with us because they just can't take the stress. So I think we need to concentrate on that as well. Now, I would like to ask the last question of the today's discussion to Dr. Suruchi about this germline testing once again. So, how has been the acceptance of this test among the doctors and the patients in India since we have started doing these tests of late, and it has many implications as well. So, Dr. Suruchi.
Yes. The acceptance of this test among the doctors is for ovarian cancer. Upfront testing has been recommended according to guidelines also, and we are seeing that doctors are recommending upfront BRCA1, BRCA2 testing for ovarian cancer patients, especially high-grade serous ovarian cancer patients with or without family history also. Among patients, it is little difficult because there are many social implications. And for that, I would say genetic counseling, pre and post test genetic counseling is very important. So most of the testing companies, including our lab, they offer free of cost genetic counseling, pre and post test genetic counseling, which is very important for the caregivers and the patient itself. What is the implication of the test? What will be the test result? How it will affect the family, and what are the different further management plans based on the test. So among the patients, it is still difficult in India due to social implications, but clinicians' acceptance is okay for ovarian cancer. And for breast cancer, it is still germline testing is they do in advanced stages only, not upfront. As far as there is a trend of doing germline testing for breast cancer in advanced stages as compared to the ovarian cancer, where they accept it at upfront also. And again, as I mentioned, that tissue-based testing in ovarian cancer is important to do as compared to germline testing, because it will pick up both germline as well as somatic variations, which can be tested further for other, like for germline predisposition.
Okay. Thank you, Dr. Suruchi. I think it's very important that we utilize the genetic counseling. Counselor for having a discussion with the relatives and the patient before and after testing. I think before and after testing, that's very, very important. That solves many of the confusions, issues associated with this particular test. Because it has a lot of implications. Many of them actually get depressed following the test results in case they come positive. We have seen that. So that's very, very important. We may not be able to concentrate or educate or even counsel them on every aspect of these tests. So I think utilizing the counselor is a very, very important thing. So thank you, all of you, my esteemed panelists, for such a wonderful discussion on this particular condition. So hopefully audience and general public would get help from this discussion. Thank you so much for taking out your time, such an important time in this afternoon. Thank you very, very much once again.
Thank you, Dr. Vivek.
Thank you, Dr. Vivek, for moderating this.
Thank you.